This microphone will probably burn through it in about 5 minutes or so, but the stomach is designed and adapted to accommodate that acid really, really well. So the fact that the stomach environment is acidic is not something to worry about. In fact, it plays a really important role in starting the breakdown of certain foods and preparing the molecules that go into your gut for absorption. At the same time, because it's such a densely acid environment, giving a supplement to change the acidity of the stomach basically doesn't work. The only ways really of alkalinizing your stomach are to take very potent acid-suppressing tablets, which many people do, like omeprazole and toprazole, or to vomit excessively. The duodenum is, or duodenum, if you prefer to pronounce it like that, is designed to produce your bile to help neutralize the acidity of the stomach and to prepare the food for transport down the small intestine. And it's where your pancreatic enzymes come into your gut to break down the fats and proteins of your food. The small intestine, the 3.5 meters or so small intestine, is where most of your fat, vitamin, and mineral absorption is taking place. And then your colon is where we can kind of slow everything down, aid the absorption of water, form your stool, and provide continence and the last few steps. And there's a few very specific things happening. So like I say, the stomach is full of hydrochloric acid. The small bowel has this adaptive membrane with villi with these tiny little finger projections, which increase the surface area to something like 20 tennis courts if you were to flatten it all out and stretch it out. So you can imagine that something that affects that is going to affect your absorption, your ability to absorb fat and minerals significantly. And in the bowel is home to trillions of bacteria, many of which would be pathogenic diseases if they were to be injected into your bloodstream, but in the bowel themselves sit in comfortable balance between, in inverted commas, good bacteria and bad bacteria. I'm going to talk about that a little bit in a while. So, and there may be some formatting issues on some of my slides going forward, like this one, but I'm going to talk about the questions that patients often come into clinic and say to me, and I'll try and show you where that may be true or where I think that those questions don't necessarily align to the evidence we have at the moment. So a very common one is, I'm pretty sure I have inflammation in the gut, or something along those lines. I'm feeling really inflamed today. I'm having a flare of my gut inflammation. And when you see a lot of those social media influencers and the way that they talk, this language is often reflected there as well. So what actually is inflammation? And going back to my schematic, well, the way that I consider inflammation is primarily, particularly when it comes to the gut, active processes involving the immune system that have the potential to cause damage to the tissue of the gut. So if you take the small bowel, those little finger-like projections, conditions like celiac disease, where your body's immune system is reacting against the gliadin protein or section of the protein that is within gluten-containing products, can set up an inflammatory reaction that actually flattens those villi. So if you imagine that you rely on 20 tennis courts to absorb the food that you eat, and then that's all flattened down to 1 or 2 tennis courts, you can imagine that's going to result in diarrhea and bloating and abdominal pain. It's one of the things we often look for when patients present with those sort of conditions. But that's something we can see. It's something we can test for. We can see it in blood tests. We can see it on biopsies. So frequently, if patients come in with weight loss, bloating, diarrhea that's otherwise unexplained, particularly if there's anemia, we'll do an endoscopy, we'll take a biopsy, we'll look for this. But if it's not there, if there's no villus atrophy or inflammation in the small bowel, then something else is causing that symptom. So let's look at the other places where inflammation can affect the bowel. One of the things that I see very frequently in my practice as part of my specialty is inflammatory bowel disease. So these are disorders where visible inflammation is taking place in the colon or in the small intestine. Ulcerative colitis is the condition where the bowel is inflamed continually from the anus, potentially all the way up to the end of the colon, whereas Crohn's disease could affect anywhere in the bowel. But they're characterized by, like I say, changes that you can see: ulcers, inflammation, bleeding, granularity. So inflammation that I can actually see with my eyes when I do an endoscopy. It's another one of the reasons why when we do a colonoscopy for screening purposes, or for symptomatic reasons, when someone presents with diarrhea or a change of bowel habit or blood in their stool, then this is what we're looking for. And if I don't see inflammation visibly, I may take biopsies. But if I take those biopsies and it's normal, then there probably isn't inflammation at the level of the gut. Now, there are other forms of inflammation. The systemic inflammatory conditions like rheumatoid arthritis or systemic lupus and all the other connective tissue diseases. These are also conditions that are related to inflammation in the body, dysregulation of the immune system, and the body kind of sending immune cells to set up these inflammatory responses somewhere else. I'll touch on a little bit whether the gut can be relevant to those. Inflammation is thought to be very relevant in cardiovascular disease, a form of low-grade chronic inflammation that allows the inside of the blood vessels, the endothelium, to become irritated and inflamed, and in turn lets those rupture, and then plaques of calcium can build up, fat can be deposited, and that's what coronary artery disease is, or peripheral vascular disease. So inflammation has roles outside of the gut and outside of the body, and also has a role in cancers of the bowel as well. But that's more indirect. And so when I talk today about gut inflammation, I'm going to focus on those first couple of things, the inflammation you can see, biopsy, see under the microscope, that's a direct cause of symptoms in the bowel. But we will touch a little bit on the cancers and the inflammatory joint conditions as well. Okay, so I do a lot of colonoscopy as part of my work. A lot of those patients will be coming for their screening colonoscopy from age 45. We recommend 10-yearly bowel cancer screening, which can be colonoscopy. It doesn't have to be colonoscopy. There's other forms of screening as well. And my one message, I just want to reinforce right now, is have your screening, one form or another, whether it's Cologuard every 5 years, or a stool test for fecal immune testing, looking for blood every year, or it's a colonoscopy every 10 years. Do not put off your bowel cancer screening. A lot of people put it off. It's not a nice thing to think about, but it's an important thing to do, and we're pretty good at it these days. It's pretty straightforward. A few days of bowel prep, which isn't the most pleasant thing. Come in, we'll give you sedation for the procedure. It's done within 20 minutes, and the risks are extremely small. So that's just my plug for screening endoscopy, and please make sure you get that. But the majority of people I scope are going to have a bowel that looks like this. On the left side, that's one of my patients from this week. You can see that there's some shininess to the wall of the bowel. It's a nice light kind of salmon pink color. You can see that there's rings of the bowel. These are the circular muscles that kind of are present throughout the colon and the entire bowel. And I don't see any redness. I don't see any inflammation. So again, inflammation has this sort of almost mythical status in the world of health, of certainly health influencers and the stuff we see on TV. But inflammation is often something you can see, and I don't see any inflammation here. So when I do this colonoscopy, I'm 90% sure whatever the patient's presenting symptoms, that there's probably not a dangerous underlying inflammatory condition affecting their bowel. And on the other side, this slightly busy picture shows what's normally going on at a microscopic level at the level of the bowel cells. So at the very bottom, those are the intestinal enterocytes. What's interesting about the bowel is it's pretty much one cell between the dirty internal layer of the center of the bowel, which is where the food you eat and the stool you create is produced. One cell separates that in your bloodstream, your capillaries, which then feed into your cardiovascular system, first to your liver and then around the body. And that one cell is protected by a layer of mucus, and dotted throughout the small intestine, these immune cells, these dendrites, which kind of project into the center of the bowel and monitor and check for infections and pathogens and strip them out. And then there's this healthy balance between the inverted commas dangerous bacteria, the pathogenic bacteria, the E. coli and salmonellas of this world, and the good bacteria, which produce kind of help break down some of the proteins in your food, fibers in your food, and produce healthy molecules that actually feed the bowel. So that's what a healthy gut looks like. Compare that to this. which is a bowel that has chronic inflammatory bowel disease. And you can see that that nice shiny layer is gone. There's ulcers, you can't really see the rings of the bowel. The architecture is distorted. So again, this is what I'm primarily looking for when I do an endoscopy on somebody who thinks that they have inflammation or that I suspect they have inflammation. I'm looking for inflammation. If they don't have, if it looks more like this, they probably don't have inflammation. Okay? But something's happening microscopically at this level as well. So the mucus layer is gone. The cells aren't as close together. The pathogenic bacteria are closer to the surface of the bowel. So that's where we start to get systemic problems. That's why people that have really bad inflammation in the bowel can have fevers and can feel sick and can lose weight, because all this inflammation that was previously held at bay is now much closer to the body. That one cell is now providing less of a barrier, and that stuff is getting into the bloodstream and circulating, setting up an inflammatory response. Okay, so what isn't inflammation? A lot of my patients come to clinic with occasional cramping or bloating or brain fog or fatigue. You know, I have 4 kids. I've just finished a home remodel. I've got a pretty busy job. I experience at least 2 of these symptoms pretty much most days. I won't tell you which. Inflammation, these symptoms can result from inflammation, but lots of other things can cause them as well. So again, the influencers will often tell you, have you got brain fog? Have you got fatigue? Are you having abdominal cramping? We need to fix the inflammation in your body. And that's a myth. That is not true. They may be symptoms that lead us to say, okay, let's check for objective inflammation in your body. So is there anything in your bloodstream or your stool markers, or maybe an endoscopy if we think it's right to do it, that tell us that there is or isn't inflammation? If there isn't, we can move on and think about other causes. But I don't want you to think of inflammation. Inflammation isn't this. If you think about inflammation, think of this. Okay, so the next thing. I heard if I fix my microbiome, the inflammation will get better. Lots of patients are coming into clinic. I just heard an advert on the radio on the way coming in to say, I had years of bloating. I did one test and it all got better, right? So what are we talking about there? Well, I touched on this before, but there are good bacteria. There's this idea of good bacteria and bad bacteria. Where does that come from? Well, it comes from about 30 to 40 years of research now that looks at that uses the advances we've had in genetic testing to look at what's actually going on in the bowel. And what we find is the balance between species like lactobacillus and lactococcus and things like that, bifidus on the left side, and the more dangerous bacteria like enterococci and staphylococcus and clostridium. The ones on the right of your screen are generally more associated with disease. We know if we put them into the gut of a mouse that's never been exposed to bacteria in its life, we put those ones in, they get sick. They get something that looks pretty much like colitis. So they get lots of other illnesses as well. But if you only put the ones on the left into those mice, they tend to live longer, they're healthier. And what's interesting is if you put the good bacteria in first and then the bad bacteria, they don't get sick. So there's this idea that there's a balance between good and bad. And that's been held up pretty well in lots and lots of research. So going back to my example of ulcerative colitis or Crohn's disease, the inflammatory bowel diseases, you see that the balance of those bad bacteria, the ones on the right, I'm not going to read down the list, but this list of things that are kind of associated with damage to the bowel is much, much higher. And not just that, the numbers of the inverted commas good bacteria are lower. So there is a difference in people who are sick versus people who are well. And it's not just inflammatory bowel disease. You look at people with rheumatoid arthritis, there's fewer good bacteria and more bad bacteria. Look at people with cardiovascular disease. Look at people with diabetes. Look at people with cancer. These balances are wrong. So there's something there. And as a result of there being something there, there's now this enormous market of biome testing where you can take a stool sample and send it away. I get patients coming in with their reports with 30, 40 pages of different species and which ones are high and which ones are low, with a red line or a big highlight for the ones that are out of range. People saying this is dangerous, I need to fix this. And what they're bringing me is something that looks a bit like this. So it's telling me that they sit more on the right side than the left side of the screen. But I don't currently have any data that tells me exactly how to fix that. it's got to the point now you can even buy bioanalysis kits for pets. So take of that what you will, but this is my kind of summary of what we know versus what we don't yet. So there's trillions of bacteria, viruses, and fungi in the gut that live in dynamic balance. There are genuine associations with different disease states. Diet does influence the microbiome. If you have certain foods, I'm going to come to that in a minute, it will change the bacteria in your gut. And there are some success stories. Very specifically, we can really help, in fact, cure people with chronic infections of the bowel with something like C. diff. C. difficile, a really nasty inflammatory condition of the bowel caused by certain bacteria. If we give them a microbiome transplant, we get the healthy bacteria from a donor, put it in those bowels, they get better. If you have somebody who's had their bowel removed, has an internal J pouch, and that pouch becomes inflamed, probiotics can make that better, certain ones. But in most cases, probiotics might improve your bloating, might improve, some of the symptoms you have, but are likely to change your disease course or your risk of getting a disease or otherwise. So my verdict on is my microbiome causing my inflammation? We're not there yet. There's something there, but we're not there yet. Maybe we'll get there, but I've been saying maybe we'll get there for the last 20 years. We haven't got there. So I think it's more complicated than that. So let's talk about why some other things that people say to me. What about my leaky gut? Well, leaky gut's a really interesting thing because a lot of doctors, doctors are fit into different schools of thought, and there's some doctors say, oh, don't talk to me about your leaky gut, and some will say, oh yeah, let's look at your leaky gut, let's try and fix that. Patients are very influenced by what they see as well. Leaky gut is a real thing. Okay, so I talked to you before about there's just one cell of thickness between the dirty internal environment of your bowel and your bloodstream. And on the left of the screen, you see that those cells are close together. There's what we call tight junctions between them. That's keeping the bad stuff out. And it means that everything's filtered through the cells themselves and your immune system. But what sometimes happens in disease is that those cells get a little bit further apart. And the pathogens, those bad bacteria, the toxins in the bowel can get through and they can get into your bloodstream. And we can actually detect that. So if we take people with Crohn's or ulcerative colitis, and these are busy slides, but the take-home message is the more severely inflamed they are, the more we detect things that should only be inside the bowel in the bloodstream. Right, so big molecules that are markers of bacterial things that are in the bowel that can't find their way into the bloodstream because there's no way for them to get there. When you're sick, they find their way into the bloodstream. So that's sort of one of the things that leads the influencers and others to say, hey, it's your leaky gut, let's fix your leaky gut. Well, it's only part of the story because there's other things that we find cause this as well. Right? It doesn't mean inflammation. If we dehydrate people, this is the figure on the left. If we dehydrate people, their gut becomes leakier. If we exercise people, high intensity intermittent exercise, their guts get leakier. Do not take this as a message not to exercise. Right? This is just saying that when you exercise, something changes. So this is probably a natural part of how the gut was developed, part of the way that we expose our immune system to certain pathogens that they wouldn't otherwise be exposed to, that allows us to develop some immunity. It's another reason not to go and do those food sensitivity blood tests where you send stuff away and they give you a long list of molecules of foods that they think you have an immune response to, because often it's just reflecting this, the normal exposure. So leaky gut, facts versus fictions. Tight junctions get less tight with disease, but strenuous exercise, lack of blood flow, and some chronic conditions can also cause this. There are some interventions that improve the gut barrier. We can give some probiotics do, some supplements like glutamine can. But to be honest, most of this work has only really been done in animals. There is no evidence that losing the barrier is the cause of disease, and no disease has ever been cured by making the gut less leaky. Okay, so just put it in perspective. Don't waste your money if someone's trying to sell you a supplement specifically for leaky gut. But be aware that it's a thing that exists and maybe part of a bigger kind of immune process going on. Okay, so what about, I'm worried that my diet caused my inflammation. I get patients come in and there's always a guilt when we diagnose them with Crohn's or ulcerative colitis, saying, what have I done to cause this? I used to have a pretty hectic life in my teens or in my college years, and did I cause this? Well, let's look at what we know. So again, some of these slides are a bit busy, but I'll tell you what they're showing. So this is one of the kind of more definitive population level studies that that told us that when patients have so there's this thing called an EDIT score, which is basically an inflammatory score of the foods that people eat. There's a lot of work over many, many years has gone into whether some foods create an inflammatory response. And the studies were pretty amazing. There are hundreds of thousands of people that donated blood and filled out food diaries. There's some problems with those studies as well, but they're kind of what we have. What we found is that patients who have a higher EDIT score, so eat more foods like burgers and red meats and processed meats and sodas, were more likely to get Crohn's disease, almost 1.5 times as likely. So, it's a relative increase, but across the population, it's an important change. And those that followed a healthy diet were much less likely to get those conditions, healthy in inverted commas. And when I say here, what's going on and why are these foods inflammatory? Well, these patients get higher levels of CRP, the inflammatory protein that we're often looking for in healthy disease, interleukins, TNF. So these are all like systemic inflammatory markers that indicate an activated immune system. So then, a lot of thought has gone into, so why is this? Why does this happen? Why would certain foods be inflammatory more than others? And that's where this idea of ultra-processed foods has come from. So ultra-processed foods are something you're going to hear a lot about. People have strong opinions of them. There's now a bit of a counter movement about ultra-processed foods that have gone too far in defining things as ultra-processed. Ultra-processed foods, by definition, are energy dense. They're foods that have required some form of processing, like addition of salt, oils, or like commoditization, like taking things down into a powder form and then reconstituting them in order to make them either more palatable or have longer shelf lives. They tend to be lower in fiber, protein, vitamins, minerals. They're higher in sugar, fats, and salt. And my definition of an ultra-processed food is like, how long is the label on the back? Because something that has more than 10 ingredients, particularly if you read them and you don't know what that thing is, it's likely to be an ultra-processed food. And why is that relevant? Well, what happens is all to do with that. If you cast your mind back all the way to that healthy-looking bowel and the mucus barrier that we had. So what's happening is these foods have a lot of emulsifiers, so they are naturally good at dissolving fat and at they're also the exact foods that the bad bacteria like to eat. So they cause an increase in the pathogenic bacteria within the bowel, whilst reducing the barrier of the bowel, and they allow the cells to get a little bit further apart. So kind of all the things we talked about before, microdysbiosis, leaky, all those things are kind of caused by ultra-processed foods. And as a result, you get these inflammatory responses that then set up an issue in the body. And like I say, I just showed you the data to show that you're more likely to develop Crohn's if you've been exposed to these, but not just Crohn's. Western diet's been associated with high sodium, with cardiovascular disease, with stroke, with diabetes. So when you kind of look at the news and you see the new food pyramid that's inverted, that's saying, low refined grains, higher whole foods, more balanced kind of unsaturated fats, fish oils, and plants, they're not wrong, okay? Because this is the sort of data that's been informing that. So there's a lot of, regardless of what your politics are about it, there is a lot of data to support that these dietary changes have at least contributed to chronic disease over the last generation or so. But it isn't so simple. And I'm going to keep inflammatory bowel disease as my kind of reference point here. But it kind of applies to all of them. It's not just the environment and the food you're exposed to, it is the microbiome, but you've just shown you the microbiome will respond to the foods you're exposed to, but it also responds to your own immunology and your own genetics. So all those things together, are where the interplay that then creates a perfect storm for you to develop a chronic inflammatory condition like inflammatory bowel disease comes from. And this could apply to any chronic condition, okay? So my verdict on that is diet clearly matters, with a small caveat that it's not the only thing that matters. And I don't like my patients to leave the clinic thinking that they are guilty of causing their inflammatory bowel disease, because typically they're not. the environmental things that contributed to their condition were not their fault usually. And some of these things can be altered and changed and improved. And so the next question I get is, well, can I cure my condition with diet? Cure is such a strong and emotive word, isn't it? And like, you only need to look around to see claims of this all around on the internet and the media. She cured her chronic condition with a vegan diet. Woman with cancer says the diet that saved her life, and healed thyroid cancer. These are, whether it's cancer, inflammatory bowel disease, there's always people that claim these things, but I'd say most of these claims, at least stated like that, are false claims. Okay? I'd love them to be true. I'd love nothing more with an interest in specialty in nutrition. I'd love nothing more than people to be able to cure their cancer with a change in diet. But unfortunately, it's not the case. What is the case is you can make significant improvements. And this isn't as exciting, doesn't make as good a headline, but I don't think it's any less important. That so in inflammatory bowel disease, we're particularly interested in diets these days, and rather than throwing more steroids and more drugs, are there other things we can do? And we know that now that things like the specific carbohydrate diet or Mediterranean diet can show a significant improvement, up to 50% response in symptomatic remission, but not just symptoms, in the improvement of like objective markers of inflammation, like stool inflammatory tests, like fecal calprotectin, or blood tests like CRP. So diet has a role, and there's even more like impressive or extreme examples. So in patients with small intestinal Crohn's disease, we can actually stop them eating and supply liquid nutrition, either in milkshakes or tube feeding. And this is particularly, so you can imagine adults aren't very good at doing this, but kids are great at doing this, because, well, some kids, they'll do what they're told. What happens is everything gets better. So if you expose the gut to not just the complex elements in our diet, even in inverted commas healthy diet, you actually take that all the way down to the building blocks, the fats and the proteins, even the amino acids rather than the complex proteins, the sugars in the right proportions. Inflammation of the gut improves at least as well as giving them steroids with the diet. And so we can actually prevent people needing to go to surgery for this. So I do discuss these diets with my adult patients as well, and usually we end up with something that is more of a hybrid, something called the Crohn's disease exclusion diet, where you take away the complex foods for a period of time and you introduce them slowly. These diets have also been shown to be beneficial in other inflammatory conditions, rheumatoid arthritis, SLE, psoriatic arthritis, dermatological conditions, and even some cancers. So again, I don't want you to take this as I'm saying diet can cure cancer, which it can't, but there have been some very good studies that have looked at multiple well-designed clinical RCTs over time. And if you look at the meta-analysis of those studies, better overall diet quality was associated with improved survival. This is breast cancer and colorectal cancer. It's been found in others as well. Particularly adherence to a Mediterranean diet, and that could be up to a 23% reduction in 5-year mortality. So diet's clearly important. Now, that's not just going to be that the diet is curing cancer. The diet is continuing to supply the health systems that are required to fight that condition as well, or to tolerate the chemotherapy and the other things. That's why diet's so important. So it's not a cure, but it's a pretty good treatment. Okay. So where does that leave us? I've talked about the microbiome. I've talked about leaky gut. I've talked about diet as a cause. I've talked about diet as a treatment, and I've talked about other conditions that can be helped here as well. But it's a lot of information. So my bottom line summary of this is that meaningful inflammation can usually be seen on lab test endoscopy or imaging. So just saying I feel inflammatory, you're not going to be talking necessarily the same language as your doctor. So we can look for inflammation in blood tests and in endoscopy in clinical examination. And we may not find evidence of that inflammation. And by that, we don't mean there's no inflammatory process happening in your body. We mean that we've not found a dangerous or progressive cause that needs a very specific course of action. So your brain fog and your bloating isn't necessarily inflammation, but it may just be an interplay between your gut and your brain and the way the nerves and the food you put into it kind of works together. The microbiome and leaky gut are important processes and concepts, but they shouldn't they're not the single thing that you should treat. They're not the difference between health and disease. And diet has a role in the cause and treatment. It's not a miracle cure. It's a pretty important one. Okay, so my practical takeaways would be, I thought I'd say this, but follow the current administration's HHS advice and eat more plants, more variety, more fiber. Limit ultra-processed foods and processed meats. Be skeptical of anyone that sells certainty. And if you have IBD symptoms or gut symptoms, work with a gastroenterologist or a dietitian, because there are causes other than inflammation. And diet matters, but it's one part of the bigger picture. So if it seems too good to be true, it probably is. Thank you very much. So,
part of Q&A?
Yes.
Any questions, Dr. I have a couple of questions. What are your thoughts about taking turmeric on a daily basis for inflammation?
So turmeric is, there's a few things that are really interesting at the moment from an inflammatory point of view. Turmeric is one of them. Curcumin is another one. And Kindai, which is a Chinese, a traditional Chinese medicine, is another one. And there's been some really good lab studies to show that they improve inflammation of the gut. Again, so the studies that have shown to be beneficial have usually started from a point that the gut looks inflamed. So I haven't found any data that says that they're healthy things to take if you've not been diagnosed with a chronic inflammatory condition of the gut. But those that did, it seems to have an additive benefit. So far it's not replaced any of the other drugs. But there's some interesting ongoing studies, particularly with curcumin and Kindai, that turmeric is being studied as well. That looks at its long-term benefit. So the short answer is yes, I think it's beneficial as a supplement, but not as a kind of game changer.
And what are your thoughts about, is there a particular region in the world, in the US, that is more susceptible to any type of IBD, IBS, or is it just all over the same data?
Well, so there's an overlap in the things that I talked about. Without doubt, the disease rates of both inflammatory bowel conditions, but also all other autoimmune conditions and cancers increase the further away you get from the equator. And the things that I talked about are thought to be part of the reason why that's happening. Not the whole reason, but part of the reason. We think some of it is with better at diagnosing things, and we have more or different access to healthcare. That bowel cancer screening programs don't happen everywhere. But some of it is a real kind of phenomenon that we're at the more extreme latitudes, we see more of this disease.
And last question, I think I asked you that, I think I want to share with everyone. Men and women, what percentage do you see more of Crohn's disease in men or ulcerative colitis in women? What are your thoughts?
So there's an interesting phenomenon of autoimmune conditions tend to be more common in women than men. And say it does apply to inflammatory bowel disease. There's a slight increased percentage of women versus men. But it's still like, maybe 53, 47, 55, 45. It's not, 80, 20. And we're not entirely sure what that is.
Thank you.
To talk about turmeric, what's the difference between powdered turmeric versus fresh? There's a lot of controversial.
Yeah, I'm not familiar enough to be able to comment on that. The powdering process is going to change it to some extent. Usually, and this is a general statement, not without knowing what the data says. Usually, when we're powdering something, we're concentrating it, and that can have both good and bad effects because often we have to add. It's a bit like processing. Right? It's kind of an ultra-processed food in another sense. So I don't know what else is added during the powdering process, how pure it is, etc. That may make a difference. On the flip side, fresh turmeric may not have as high a concentration. With some of the other supplements we give, the studies that show they're effective, things like arginine or nitrates, which can help, sodium nitrate can help preserve gut barrier function. If you buy it in a store, the level is something like a tenth of the level required in the clinical studies to see a change. So sometimes there's a concentration kind of question as well. So I'd have to look into it.
Okay.
Yeah.
Besides physician visits and annual checkups, what are the symptoms that we should not ignore and we have to just rush into the specialist right away?
Yeah. So from a lower GI point of view, if I'm reading through a referral or somebody's asking me, should I be worried about this? A persistent change in bowel habits. Everyone can have a loose stool here or there, but a persistent change of bowel habit or frequency, so going, several times a day, persistently, especially if it's associated with pain, especially if there's blood mixed in, especially if it's associated with weight loss. They're the things I would consider to be red flags. That said, any symptom that persists for more than, say, 2 weeks, you should discuss with someone. If it's new and it's changed, or you have a concern. That doesn't mean that will automatically lead to investigation. I will say most patients that present at any age with a change of bowel habit towards diarrhea, especially if there's blood mixed in, will end up getting a colonoscopy because of the chance of finding inflammation and the importance of not missing it.
What do you think about taking glucosamine supplement for pain, joint pain or inflammation?
Yeah, so glucosamine's been around for some time and it has been studied, and there's a lot of reports of people finding it beneficial. The last time I checked the data, which was some time ago, it tends to be people often take glucosamine for joint issues, so I'm less exposed to it on the GI side. People often ask me, is it safe to take, and I always say yes, it is. But my understanding of the data last time I looked was it's not black and white. There's some people clearly get benefit from it, but and it probably does have effects on the immune processes in parts of the body. But if the problem is, for example, osteoarthritis, wear and tear, it's not going to change the fact that if there's bone on bone kind of grinding against itself, or there's chronic kind of changes in the joints, probably won't change that, but it may improve the symptoms.
Any other question?
Any evidence on physical health and exercise with gut health?
Yeah, so it's kind of a whole other talk, and it's something. It's a big interest of mine is the digestive health of athletes. So a couple of things. Professional athletes tend to have healthier biomes than the general population, even, and certainly than those with disease. So that may be a product of their nutrition or the training itself. I showed you that the gut does become intermittently leaky. We think that might actually be a good thing in helping strengthen the immune system. But there are some conditions where exercise actually damages the gut. So extreme endurance sports, if we check their stools afterwards, and some people have done these studies, have been involved in some of these studies, we find increased inflammatory proteins in the bowel. Even if they have an endoscopy, we often see ulceration and inflammation. But that's at the most extreme end. And we think what's happening there is you're shunting blood away from the gut to the muscles, into the skin, into the lungs, into the heart. And so it's not getting to the bowel. And so the bowel is kind of suffering, a transient damage. And every year at marathon or endurance events, there's collapses, and there's people end up in intensive care, or there's cases of ischemic colitis. We think that a lot of that is related to the same process. We just don't know exactly which people that will happen to, and that's a subject of ongoing investigation. As it happens, I'm trying to set up a clinic at the Samueli Institute for exactly that kind of thing.
Any question? No? Thank you. Thank you so much. Thank you. Our next speaker, it's a good friend, Dr. Yazdan Pano. He's a board-certified UCI health medical oncologist who specializes in the treatment of genitourinary malignancy, including prostate, bladder, kidney, and testicular cancer. His clinical interests include precision oncology, molecular profiling, and clinical trial development for patients with early stage and advanced cancer. Please help me welcome Dr. Yazdan Pano.
Good morning, everyone, and thank you, Kip, for the introduction. Thank you, Dr. Fer, for the presentation. I hope you all had bought your probiotics and vitamins from somewhere that you can return them seamlessly. Well, my talk today is about prostate cancer screening. And is it a powerful ally or an unnecessary ally? So this cartoon kind of summarizes the 30 years debate about prostate cancer screening. Someone yelling on one side, PSA screening saves lives, and the other side, what about overdiagnosis and overtreatment? And the poor patient in the middle, wondering why everyone's yelling, he's the one who is in trouble. So, is it a powerful ally or unnecessary alarm? The Family Guy on the right, this is what a lot of people imagine from prostate cancer screening, an unsophisticated and not nuanced discussion, but an unexpected and awkward examination. Well, the good news is that with the modern PSA screening and the prostate cancer screening, that's not the case for a lot of the patients, and it's more sophisticated. And I promise no one is planning to recreate that test here. Why prostate cancer matters? So we all know this is the most common cancer among men after skin cancer. And as we can see here, around 313,000 cases of prostate cancer we had in the United States. This is the most common cancer involving men. And as you can see, it is followed by lung cancer, colorectal cancer, and melanoma and skin cancer. The thing that is important to look at here is the mortality. How many patients are going to die from prostate cancer? That number, when you compare with the other types of cancer, is not that high. 35,000 out of 300,000 is going to be around 12%. That number for lung cancer is more than 50%. For colorectal cancer is more than 30%. So there is a longevity with the prostate cancer diagnosis, but not for everyone. Still, we have a big number, 35,000 of patients dying every year from the prostate cancer. We want to look at this question, if the prostate cancer screening and PSA screening can save life. So we're going to look at the staging first. Most of the patients, 70% of patients are being diagnosed with prostate cancer at a localized stage. So it is limited to the prostate itself in the pelvis. 14% are regional. By regional, we mean us oncologists, that is limited to the pelvis area. There is a lymph node there and there. But around 8 to 10% of the patients are being diagnosed with distant metastasis when the prostate cancer is spread to a place outside of the pelvis. That drives the mortality. You can see if the patient is diagnosed with localized or regional cancer at a 5-year point, 100% of them are going to be alive. But when that patient is diagnosed at a metastatic level, that number falls by 63% to 37% of them are going to be alive at 5 years point. Prostate cancer is a cancer of older individuals, but still we can see around 6% of that can happen below age 55. This is something to consider. These are the patients who are higher risk. These are the patients who have family history of prostate cancer. These are the patients who have some germline risk factors, mutations that put them at risk of prostate cancer. Black community, Black patients, there are a lot of them being diagnosed with prostate cancer at early age. These are the patients who are not going to be screened, who are not thinking about prostate cancer. So this brings up a good point of precision oncology and look at every patient specifically about their own risk factors, about their own racial background, and other genomic profiling that can put them at risk of prostate cancer. So here we're looking at a 20-year epidemiologic trends of prostate cancer. The first thing that grabs the attention is the spike around early 1990s of the prostate cancer diagnosis, because that's when the prostate cancer screening was adopted universally. American Urology Association and American Society of Clinical Oncology recommended PSA screening for all men above age 50. So everyone's getting screened, A lot of prostate cancer diagnosis happened in that era, but our understanding of PSA screening changed over time. It was around 2008 that United States Protective Task Force actually recommended against prostate cancer screening above age 75, and in 2012, they actually completely recommended against PSA screening. What were they afraid of? We're going to discuss in a few slides, but you can see the diagnosis of prostate cancer starting to decline around that time after 2012 because we stopped screening. The mortality, if you look at the death rate, which is the lower curve, it was going up initially because of a lot of cases being diagnosed, and then it has trended down and has plateaued, although it is declining steadily but very gradually because of better treatments that we have these days, because the patients are being diagnosed and can be treated and live longer with prostate cancer. And this is reverse the reverse curve of the mortality, that shows the patient's survival has becoming more and more better, and people's prostate cancers are living longer. But we looked at this. We looked at the USPSTF PSA screening policy changes and its effect on the diagnosis of prostate cancer. The first spike, it was pre-2012 widespread PSA screening. At 2012, they stopped. They recommended against, so the PSA prostate cancer diagnosis plummeted. But after around 2018, with the newer data available, they actually recommended shared decision-making for the patients between 55 and 70, and taking into consideration of how long the patient is going to be able to live to screen those patients for prostate cancer. But the important thing here is the distant stages. You can see there is a rise after stopping the prostate cancer screening for the patients being diagnosed with prostate cancer in a distant stage. I showed you a slide. When the prostate cancer is diagnosed at localized or regional stage, the 100% survival rate at 5 years point. That number was 37% for the patients who are being diagnosed in distant stage. Some people argue that, with the better treatments that we have, those patients are going to be living longer and the mortality is not going to be affected. But apart from the mortality, which is the main topic of today's talk, we always need to take into consideration, even if we have great treatments, even if the patients can live longer with these new treatments, they're going to be taking treatment. So there are side effects with the treatment. There's financial toxicity with the treatment. So these patients are going to be on these medications for a long time. So there's financial toxicity.
If you want a laser,
Sure.
you can verify. Sorry.
Let's see. How's it working? Okay.
Yeah. You need to push that button.
Yes.
There you go.
Yes. So those patients, treatment for a long time for the financial toxicity in the healthcare system, insurance system, and the families. So it's very important to take into consideration that prostate cancer screening distant stages started to rise after the change of the policy. But why those policy changed in the first place? Initially, there was a widespread PSA screening because we had the data from original trials. One of them was PLCO, was a very famous trial, recruited a lot of patients. They were doing prostate cancer screening, lung cancer screening, colorectal cancer screening, and ovarian cancer screening. And that trial showed there was no mortality benefit for the prostate cancer screening. There was a clear benefit for colorectal cancer screening, but there was none for the prostate cancer screening and ovarian cancer screening. But later on, we found that that trial had a lot of contamination. As a matter of fact, 86% of patients on interventional arm got PSA screening, but they later found that on the control arm, there was 50% of patients that had more than 2 PSA checks. So it was a lot of contamination in the trial, and there was a lot of patients who had PSA elevated in this trial, and they were not followed up by the biopsy. So I'm going to show today how with the modern medicine, the modern oncology, we can actually make a bridge between those two lines of the cartoon that I showed you earlier, that not overdiagnosis and not over-treatment and not missing the patients who can survive prostate cancer. So here I'm going to talk about evidence. The two important trials that have shown mortality benefits for the PSA cancer screening. It is very important to consider the time frame that the study was done. This one was CAP trial. It was recently 2024. There was a 15-year follow-up update presented in Lancet Oncology. The trial was done between 2001 to 2007. There were men aged 50 to 70 in England and Wales. One-time PSA screening was done. It was not a serial PSA screening. It was one-time PSA screening, reduced prostate cancer mortality by 8%. That number in comparison to colorectal cancer is not that high. For colorectal cancer screening, we have relative risk reduction of 20–30%. That number for prostate cancer was not there, but still there is here. And talk about numbers, it means we need 1,000 individuals to be screened for prostate cancer to prevent one death. As we can see, the curves are very close to each other, but favoring the intervention, favoring PSA, one-time PSA screening. And the problem was overdiagnosis of 40%, overdiagnosis of indolent prostate cancers that are not going to kill the patient. Patient's going to die with that, not from that. The second clinical trial that was very influential was the ER-SPC trial. Just this year in November, there was an update, and that prompted me to give this presentation today because there was an update from this trial, ER-SPC trial, 2025, that after 23 years of follow-up. Those patients were recruited between 1993 and 2007, men between 50 and 70 in 8 European countries. All these good trials are being done in Europe. PSA testing every 2 to 4 years, so it was not one-time PSA screening, serial PSA screening. Mean at least patient had 2 PSA screening, and that has shown after 23 years, you see that the curves are separated. It means that the prostate cancer screening decreased the mortality, decreased the number of deaths from prostate cancer by 13%, although it was 50% overdiagnosis rate. So we had a problem of overdiagnosis, but let's talk about lives first. I showed you in that slide that although the prostate cancer is not causing a lot of death proportionally, but there was 35,000 deaths annually. If we consider the absolute risk reduction, how much we can decrease the rate of death, based on the CAP trial, it is 400 people, 320 to 400 people. And based on the ER-SPC trial, we can decrease the number of deaths from prostate cancer between 800 to 1,200. Boeing 737 is the most common commercial plane that you all take to fly around. The capacity for that plane is 85 to 200 passengers. So imagine how many Boeing 737 we can save with proper prostate cancer screening based on those trials. We've got so much better in terms of PSA screening, and I'm gonna show you how. I'll talk to you that there was some patient population that were younger and being diagnosed with prostate cancer. So these 2 trials showed that men aged 50 to 70 with a 10 to 15 years life expectancy actually benefited the most from prostate cancer screening. So when we are considering PSA screening, it is important to consider the age and how long the patient is, how long the individual is expected to live longer, because not necessarily are the patients. The higher risk group, the family history, the ones who have had multiple family history of prostate cancer, African ancestry, and elevated midlife PSA predicts future risk. So it's very important for around age 50 to have one-time PSA. That's going to be an anchoring baseline for the PSA screening for the prostate cancer in the future. But how the prostate cancer screening is changing? I showed you the data, the evidence from 2 big trials that were done more than 20 years ago. But what has changed since then? So we just don't have the PSA. PSA is just a signal to go after something that might be happening. We have the PSA density and velocity. It shows how PSA is changing over time. The trend is always more important than single value, because there are a lot of false elevation of the PSA. infection of the prostate, a colonoscopy, and getting the PSA done a week after, you're going to have elevated PSA. Or and PSA density, how much the volume of the prostate in proportion to PSA value is important. MRI has revolutionized the diagnosis and diagnosis of the prostate cancer. It's a gatekeeper these days that we did not have during those trials. So just a single value of PSA does not lead to biopsy. We have something in between as MRI, very detailed imaging that can look at the prostate to see if there is any suspicious lesion. So it's going to decrease the concern about overdiagnosis, complications of the biopsy. More importantly, after the MRI, we have the MRI targeted biopsy to target the lesion very accurately to decrease the rate of complications with prostate cancer screening. And of course, the growing knowledge about genomic profiling in the treatment of prostate cancer has made a prostate cancer treatment very individualized, and I will tell you how. First of all, MRI. Multiparametric MRI is a gatekeeper these days. So if you go to your primary care physician, have an elevated PSA, refer to one of our urologists at UCI, they will order MRI first, MRI of the prostate, because it will visualize the prostate and it will show the significant, if there is any significant disease in the prostate. So if there is an indolent disease, that's not going to be picked up. If there is an aggressive disease, we can see that here. We have good stratification, risk stratification, and we are able to rule out aggressive disease, because it's not only important to look at the prostate lesion itself, it is important to see if it is locally invading anywhere. Prostate is an organ that is wrapped in a capsule. It's like a nylon wrapping around a prostate. If it has invaded that nylon capsule around the prostate, it is more important than just an indolent lesion in the prostate. So we can identify the ones that we can survey, do nothing, watch them, and the ones that are actually going to cause problem a couple of years down the road. So the clinical effects is going to be reducing unnecessary biopsies, higher yield of clinically significant cancer, and fewer biopsy course and fewer complications. And I'll tell you how, because even for the biopsy, we have better technology these days. We are fusing, literally fusing the ultrasound and MRI. 20, 30 years ago, it was just blind biopsy, then became ultrasound guided, looking at the ultrasound, not a really good detailed picture, and getting the biopsy randomly. But right now, with these technology that we have, we're going to merge the MRI picture with the live ultrasound and urology getting the biopsy, exactly knowing what lesion to biopsy, and get a couple of biopsies from that lesion. 20 years ago, they were just getting 12 core biopsies from the prostate randomly, but right now we know where to look at. So from that specific lesion, we get a couple of biopsies. So the higher, it will increase the accuracy of the detection of highly aggressive disease. Downstream effects, better treatment with selection, more confidence in active surveillance, and less overtreatment. These are the concerns that we had based on the trials 20 years ago, and led the United States Preventive Task Force to actually recommend against prostate cancer screening. So screening is a process now, not a single test. Back then, it was a single PSA cutoff and trigger systemic biopsy. Still, it showed that there was some mortality benefit. There was some benefit in decreasing the death rate. But now it's even more complex, more nuanced and sophisticated. We have PSA interpretation, we have the MRI, and we have the MRI-assisted targeted biopsy. Genomic profiling prostate cancer screening. Whoever comes to my clinic will have this genetic testing for prostate cancer, because I believe that every single prostate cancer patient is different and should be treated differently, and the guidelines are recommending that. The reason is that we are refining the risk of prostate cancer beyond the PSA level and Gleason score. For the ones who don't know what is Gleason score, a pathologist look at a microscope on the prostate cancer cells and look how different and how abnormal those prostate cancer cells are. And they will score them from 3 to 5. And then the two most common abnormality is going to be defined as the risk of prostate cancer. You might have heard prostate cancer 3+3, prostate cancer 4+4, prostate cancer 5+5, and it's actually a spectrum of being aggressive, being more and more aggressive. But that test is very subjective and is not going to actually show the full picture about prostate cancer. We know that the genomic matters these days, the mutation matters. We have Decipher score these days that can risk stratify and show how the prostate cancer is in terms of aggressiveness and predict the aggressiveness in the future. It will help us to guide if we need to go with surveillance, doing nothing, watching and waiting, or just going for treatment. And even if we are going for treatment, precision medicine and precision treatment of that, because it depends on the aggressiveness of the genomic profiling, how long I'm going to treat that patient, how long I'm going to put that patient on, for example, hormonal therapy. Do I need to introduce chemotherapy in the treatment plan? So new tools, what I'm trying to say is that new tools reducing harm in screening, active surveillance for low-risk disease, fewer unnecessary biopsies with the MRI, and lower treatment-related side effects. They are the things that are improving the confidence in deferring treatment or introducing treatment right away. So if we have the data from trials 20 years ago showing mortality benefit, if we repeat those trials nowadays with these tools, I predict the benefit is going to be more pronounced, obviously, because of lower overdiagnosis, lower complication, and higher mortality benefits. And AI and precision medicine is a whole another topic that I just wanted to touch on here. The integration of AI in imaging and reading the MRI, integration of AI in reading the pathology slide, integration of AI in radiation therapy, genomic profiling, all together can help individualize not only screening, but also the treatment for prostate cancer. So if you want to take something out of this, is after 20 minutes discussion, is that PSA screening was not the issue. How we think and how we perform, how we execute after the PSA screening was the problem that causing the confusion. And with newer technology, it can decrease the confusion and increase the accuracy of how we act after an elevated PSA. So prostate cancer is still a major public health issue. PSA screening can save life when done correctly, and modern tools dramatically reduce harm. So future screening will be risk adaptive and precise. Thank you all for your attention, and happy to take any questions.
I have a question. Actually, I'd like to ask you both. Hereditary. Is there a hereditary factor in prostate cancer?
Of course. So it is right now the guidelines recommend germline testing for all the patients coming for metastatic prostate cancer. I do it even for the high-risk localized prostate cancer. There are so many testing that we do. There is testing that we do on the prostate cancer itself to see what mutations are actually driving the cancer. But apart from that, we do the germline testing, and the difference between germline testing and somatic testing is that somatic testing, we're looking at the prostate cancer itself, and germline testing, we're looking at the normal tissue. And if there is any mutation in normal tissue, it means that those mutations are being actually transferred from your parents, so it has been hereditary. There's so many hereditary factors and mutations that cause prostate cancer. The most common one is BRCA, BRCA1 and 2 that can cause breast cancer too, and so many other cancers, but there's so other hereditary factors that can predispose an individual to develop prostate cancer later in life.
There are many genetic components that can affect bowel cancer, including germline conditions. To the best of my knowledge, there isn't a strong overlap between prostate cancer. Certainly, I don't believe BRCA. It's been raised. To the best of my knowledge, it's not yet been confirmed as a.
Just Lynch syndrome.
Yeah. So Lynch syndrome and the other main genetic reasons we see are things like FAP. So a strong family history of colon cancer should affect your bowel cancer screening without doubt. usually starting from either 10 years earlier than the 45 start date, or 10 years before the first degree relative developed cancer. So they developed a cancer, if a parent or a sibling developed cancer in their 40s, you should get colon cancer screening in your 30s. And usually colonoscopy is recommended over the other tests if you're higher risk.
Yes.
In my understanding, the growth of prostate gland is inevitable. Is there anything that will slow that growth that you know of?
So those are two different things. Benign prostatic hyperplasia that you're referring to, BPH, is benign enlargement of the prostate. The prostate will get enlarged over time and causes urinary symptoms, but doesn't have anything to do with the cancer itself. Those are being treated usually with medications, or if it becomes severe enough, the surgical procedure can be done. So up to my understanding, there have been so many studies to look at, what can cause the enlargement and what can actually prevent the enlargement. One of the things is testosterone replacement therapy that can cause the prostate enlargement. So a lot of individuals after, in the middle age, they get testosterone replacement therapy because it has been advertised around you have low testosterone, so you need to get your stamina back. So that testosterone replacement therapy can increase the rate of BPH. There has been very interesting study that the frequency of ejaculation can cause has some association between the size of the prostate and rate of prostate cancer. It has been shown that the higher frequency of ejaculation has been protective against the prostate enlargement, benign prostate enlargement.
So did you say that the PSA intensity, is that some kind of blood test or is it?
PSA intensity or velocity? PSA itself.
Yeah, right. Well, the PSA, and I think you mentioned another, that the PSA is not only one now, if I understood correctly. And I thought that you mentioned another test called PSA intensity. So I'm saying that.
So it's the same test, but interpretation over time. So PSA is prostate-specific antigen, is the blood test that you check one time. The velocity is the rate of that PSA going up. So you look at the PSA, for example, today is 2, and 6 months later is 3, 6 months later is 4, so it's doubling like less than a year. So that shows the velocity, the pace that the PSA is rising. And the other one is PSA density, that it actually compares the amount of PSA, the level of PSA to the volume of the prostate. So it is expected if the prostate volume is larger, because PSA is a normal marker, the PSA will be higher. So we check the velocity and also PSA density, and they take them into consideration when interpreting a single test PSA. The importance, the take-home message from that is just one-time PSA is not enough. PSA over time, the trend is better indicative of risk for prostate cancer, and how can we continue following up on the PSA level for further screening.
So how often is that recommended? How often testing?
So currently, based on the recommendation of the guidelines, is every 1 or 2 years, men between 50 to 70, and expected to live longer than 10 to 15 years, to have at least every 1 or 2 years to get their PSA checked. But that can be changed based on the individual risk. If there is a patient whose father is an individual whose father had prostate cancer at early age, that starting point of the screening should be earlier. As you saw, there were 6% of patients that were diagnosed with prostate cancer between age 45 to 55.
And did you also mention that enlargement? We were talking about that just a minute ago, that enlargement, as you get older, So is that enlargement the only way to test it is through the MRI or
There is no screening test for the enlargement itself. The enlargement can happen normally as expected by aging, but how it is usually diagnosed is based on the urinary symptoms that can happen, and usually with an ultrasound, you can see the volume and the size of the prostate that is causing those issues. So it's usually being diagnosed with an ultrasound. So rarely needs MRI.
thank you.
Any question? Thank you.
Of course.
Thank you so much. We appreciate you. Thank you. Please.
Yeah, I have a question regarding the UCI help, and is that the one that is in orange? Is that?
Well, we have actually 60